We are just delighted today to have Dr. Qiana Brown with us. We have, due to a series of unfortunate events, including ice storms and all sorts of weather conditions, this is a rescheduled webinar. So we're thrilled for those of you who are able to join today for this rescheduling. And just delighted that Dr. Brown is able to join us today and kind of went with our whimsy of last minute cancellations due to weather back in January. I can't say enough positive things about Dr. Brown. She is just an amazing researcher, community-based researcher, and contributor to service, especially in the drug use, substance use prevention field. She's trained as an epidemiologist, translational scientist, social worker, and is currently an assistant professor at Rutgers University School of Social Work. Her work has a strong health equity lens, focuses on system-level change to improve maternal and child health, and is really centered on preventing prenatal substance use and examining the role of the built environment, social environment, health, and social policy in shaping substance use and other health outcomes, particularly among women, youth, and families. Just a few words kind of about, I found the amount of service and contributions to our community you're doing are just tremendous, Dr. Brown. So Dr. Brown was named one of the Society for the Study of Addictions Women of Future Influence in Addiction Science. And you are currently an editor for the Journal of the Society for Social Work and Research. You're a member of the editorial board for Drug and Alcohol Dependence, American Journal of Drug and Alcohol Abuse, Substance Use and Misuse, and the Journal of Substance Use. So thank you for all of the service you're doing for those of us listening who are submitting papers to some of those journals. And finally, in addition to all that, you're a member of the board of directors for the College on Problems of Drug Dependence. So just truly remarkable. I greatly appreciate all your expertise that you're here to share with this group today. For those of you listening in, you will see a Q&A on your screen there, and that's where we're asking that you submit your questions. And don't use the chat, but use the Q&A. And then at the end, Dr. Brown and I will hope to get to some of those questions. And then the other thing I want to let you know is that you will, at the end, you'll see, for anyone who is wanting continuing education, continuing medical units, you'll see a pop-up screen around 10 minutes or so before the end of that, before the top of the hour. And that is where you'll fill out a brief survey to complete information to help you get your CEUs. So with that, I am just delighted to turn the slides over to Dr. Qiana Brown to take us through your presentation today. Thank you.
Thank you so much, and thank you for introducing me. I would have sent a much shorter introduction had I known, but thank you. I want to thank the CPO again for inviting me here to speak with everyone today. I'm certainly happy to be here to discuss prenatal cannabis use and maternal and child health in the context of cannabis use legalization. But before I get into cannabis use specifically, I like to tell you a little more about myself. Not that anything was left out of the introduction, but I just like to say it in my own words, like, why am I here? Why am I passionate about this work? Why am I talking to you, right? So it's always been my career goal to address or to work rather at the intersection of substance use and maternal and child health. But my career path hasn't been linear. It sounds pretty linear, but it really wasn't. I started my career off as an Army nurse. I was on active duty, and I primarily was a med surg and pediatric nurse. So I did not treat many patients with substance use disorders. So I went on to earn degrees in public health and social work. And along the way, I found founded and directed for a period of time a substance use treatment center for women, James House of Inspiration, named in honor of my late mother, pictured here with me. And she battled substance use disorders throughout her life, cycled through periods of relapse and recovery. And we're here in this picture celebrating a moment of her recovery. And even though the celebration was for her, she brings gifts to the party for me. As you can see in this picture, only a mom, right, would do that. So I like to show this picture as a reminder to everyone that there are real people and real families behind the statistics and science of addiction. And I also like to start, my talks off in this way with a summary of my work and my training as a reminder that we cannot do this work alone, right? Despite the interdisciplinary training, we have to collaborate. This is the door that we have to walk through together to fix the broken systems that are related to substance use and recovery. We can't work in silos. We have to partner. And in addition to partnering with one another, we have to partner with communities and let communities lead the way to their health so positive health outcomes can be sustainable. And I want to be clear that I'm not saying that we, the collective we, that we're not already doing that, right? That we're not already partnering, particularly partnering with communities. And I know some of us are, and we do this every day. I'm not questioning that. We're doing good work. But I am questioning our collective effectiveness in doing so, right? As it's related to substance use disorders, particularly prenatal substance use disorders, right? Between us, we have decades of training. I have several degrees myself, and I'm sure many of you have even more training than I do, right? Thousands of publications between us, the collective. We've treated countless patients just for them to return for the same conditions, right? So I'm wondering how effective we are in our efforts to work with one another. Because public health, substance use disorders, it's still a public health problem, particularly prenatal substance use disorders, right? In some communities, there are more tobacco and alcohol outlets in the neighborhood relative to grocery stores. So people can access drugs and alcohol easier than they can access fresh food, right? So we have to do something differently in addition to the good work that we're already doing to make more progress. So I'm hoping that today, as I get into cannabis use, particularly prenatal cannabis use, that it's something that I will say that will inspire you or encourage you to do something differently in your research and practice to improve the lives of patients, clients, and families over and above the good work that you're already doing. So these are some questions that I want you to keep in mind as I go through this talk on cannabis use amongst pregnant individuals and women and people assigned female at birth that are of reproductive age, that who are not pregnant. And you can pop out cannabis use and fill in the blank with whatever drug you're studying, or for that matter, whatever health condition you're studying. This is a health equity perspective, right? So it's cannabis use here, prenatal cannabis use here, because that's what I'm going to talk about. But if you need to make this more relevant to you, fill in the blank with whatever you need it to be. So what is your role? That's where we're starting at. What is your role in preventing and reducing disparities in prenatal cannabis use at the clinic and populations level, right? What is your role in addressing social determinants of health associated with prenatal cannabis use? Is the current system working? If not, what can you do to help change it? And importantly, what support do you need to drive change? So, why does it matter? Why are we talking about prenatal cannabis use now at this moment, right? So cannabis use, according to the research, the current state of science, is associated with poor maternal and child health outcomes in both human and animal studies. Now, certainly more research is needed, more longitudinal, well-controlled studies are needed to assess causation. But the state of science is what it is currently, and we see associations. So there are poor maternal and child health outcomes associated with prenatal cannabis use. These include maternal anemia, low birth weight, neurodevelopmental deficits, and given the current state of science, recommendations from health promoting organizations like the American College of Obstetricians and Gynecologists and the American Academy of Pediatrics, they recommend abstaining from cannabis use during and around the time of pregnancy. Right now, there's no safe level, no known safe level of prenatal cannabis use or cannabis use postpartum, particularly during breastfeeding, that we know of in the research. So this is why the recommendation is to abstain. Now, as research continues to occur, maybe we'll have new knowledge, but right now, these are the recommendations. Despite these recommendations from major national health promoting organizations, cannabis use has increased in the US. So this is a study that I've published in 2017 in JAMA, and since then it's been replicated time and time again. But I'll just start with my, the base work, right? So using the National Survey of Drug Use and Health, a nationally representative study, my colleagues and I, we assess prenatal cannabis use. This is the left side of the figure. And we assess cannabis use among non-pregnant reproductive age women and and people assigned female at birth in the US from 2002 to 2014. Now, writing this paper, I hypothesized that certainly amongst all reproductive age women, cannabis use would be increasing because it would follow the trends in the general population. We have no reason to believe that it wouldn't. But I hypothesized that that trend would be driven by non-pregnant reproductive age women and people assigned female at birth, and that the trend during pregnancy in cannabis use would be flat. There will be no differences, no significant differences, increases or declines, right? This makes sense because pregnant individuals have a strong motivator to quit, right? Or to reduce use. That's the pregnancy. Non-pregnant reproductive age women and people assigned female at birth have no real reason to stop using recreationally, if you will, right? So we did not see that. We did not find support for that hypothesis, at least not totally, right? What we found is that cannabis use during this time increased for pregnant and non-pregnant individuals. So amongst pregnant individuals from 2002 to 2014, cannabis use in the past month, so this is current cannabis use, increased 62%. This is this black line in the middle. That's overall use. The increase and point prevalence was even higher amongst younger pregnant individuals and lower amongst those who are older. This 62% increase in cannabis use overall represents 50,000 more pregnant individuals who used cannabis in 2014 relative to 2002. We saw observed similar trends for non-pregnant reproductive age women and individuals assigned female at birth. Cannabis use increased during the same period, past month cannabis use. It increased 47% amongst non-pregnant reproductive age women and people assigned female at birth, representing nearly 2 million more people in this bracket who used cannabis in the past month in 2014 compared to 2002. We tested interactions by pregnancy status, hoping, right? Oh, well, I shouldn't say hoping, hypothesizing that there would be a difference by pregnancy status, that because we hypothesized that pregnant women have more reason to quit. There was no difference by pregnancy status. And I know often we pass by differences that are not significant in research, but this is meaningful, right? There should be a statistically significant difference in cannabis use between pregnant individuals and those who aren't pregnant, right? We shouldn't see that trends in cannabis use increasing as much amongst pregnant individuals compared to those who aren't pregnant. This is an indicator that we need to do something differently, not just in the clinic, but at the population level. This is population level data, representative of the United States. These are pregnant people in the community. There should be a difference here, but there's not, right? So that's 2002 to 2014. As I mentioned, when the study came out, published in JAMA, it was replicated many times over. So I'll talk about some of the studies, right? Another study using the same data set, the National Survey of Drug Use and Health, replicated this work. They had more data by that time, 2 more years of data actually, and they examined trends in both prenatal cannabis use, prenatal tobacco use, prenatal alcohol use. Similar to what we found in our study, right? This blue line, prenatal cannabis use increased. But by 2016, this increase was 110% more than 2002, right? Than the prevalence we observed in 2002. So by 2014, nearly 5% of pregnant individuals had used cannabis in the past month. And this increase is significant, right? Prenatal cigarette use is decreasing. This follows trends in the general population around tobacco use, particularly cigarette use. It's been decreasing for about 50 or 60 years now. In public health, we give ourselves a lot of credit for this decreasing trend, and we should, right? But I think we give ourselves too much credit. All right, yeah, it's good that tobacco use is decreasing, particularly cigarette use, but look at the point prevalence. This is ridiculous to me. This is unacceptable. Sure, the trends are decreasing, but the point prevalence is terribly high. This is, again, in the United States. We have to do something better here and not be satisfied with, well, as long as it's going down, we're going in the right direction. Are we? Are we going in the right direction? Is this the best that we can do here? Something to think about. That's why I mentioned earlier in the slide, what can we do differently? Are our efforts and collaborating and working together and working towards efforts of prevention of substance misuse, particularly prenatal substance use, is it working as good as it can be working, right? Middle line, this is alcohol use, prenatal alcohol use. It's flat, right? It appears that there's a slight decrease, but this is a flat line. These changes are not significant. And it's discouraging, right? This, for me, I don't know how you feel. Maybe you'll tell me later, but this is discouraging. Why? In terms of population level prevention of prenatal alcohol use, there have been public health campaigns, massive public health campaigns since the 60s, well, at least since the 70s, but I believe maybe even in the late 60s, around the risk associated with prenatal alcohol use, right? Fetal alcohol spectrum disorder. Think about that. You don't have to be a scientist or an engineer or someone with specialized training to understand fetal alcohol spectrum disorder or those types of risks that are associated with prenatal alcohol use. There's been massive public health campaigns, many. There has been no similar public health campaigns for preventing prenatal tobacco use. Maybe that's why the point prevalence is so high. Research is needed to confirm that. There's certainly been no massive public health campaigns relative to those that were related to prenatal alcohol use for prenatal cannabis use. Maybe that's why cannabis use is increasing amongst pregnant individuals. My point is, given the effort that we have put into preventing prenatal alcohol use for decades, this is where we are. A point prevalence that's not zero, right? That's where it should be, but that's also not changing. That's not changing over many years. We have to do something differently, right? Another study replicating the work on prenatal cannabis use using the same data set, the National Survey of Drug Use and Health, and by this time they had 3 more years of data. They found in this study that at least from 2016 to 2017, and I see a question, we can get to that. You can feel free to ask me questions while I'm talking. So the last study that I showed you, their data, they had data up until 2016. This next study had data out to 2019, right? So from 2016, the time of the last study, to 2019, prenatal cannabis use did not increase significantly. So as of this last nationally representative study, we see that prenatal cannabis use has leveled out, right? There has been no significant changes from 2016 to 2019 in prenatal cannabis use. So that's where we are with the national trends. And I'm going to see if I can answer your question. My efforts to finding any information on the effects of use in pregnancy had not results that identify with effects. Why these effects occur, given the science, why and how is mothers. Okay, so I went over that briefly, some of the studies in an earlier slide. Maybe we can come back to this at the end. And I showed at least one study, one image that showed associations with poor maternal and child health outcomes associated with prenatal cannabis use in human and animal studies. So if you need that study out, I'm happy to send it to you. But let's circle back to that since I went over it briefly. So trends level out from 2016 to 2019 in prenatal cannabis use. Question is, why is it increasing? Though it leveled out in these last few years, there's still a significant increase from 2002 to 2019. The big question is why. I mentioned earlier that the ACOG and the American Academy of Pediatrics, they're putting out position statements. They seem to be doing their best to publicize the risk of potential risk, I should say, potential risk of prenatal cannabis use. But we see these increasing trends. And we have to think about what can we do, right? Even though some public health organizations are trying to publicize potential harms, again, there has been no effort relative to what we've done as public health in terms of preventing our public health campaigns aimed at preventing prenatal alcohol use. We're not there yet with prenatal cannabis use. Why aren't we there? I don't know. We should be there, but we're not. But people are doing their best. It's not working. So the question is why. We have to think of not only why, but why in terms of actionable steps. If there are potential risks associated with prenatal cannabis use, according to many of these cross-sectional studies, again, more research is needed. We have to ask, what can we do? What will lead to action? First, let's start with misinformation, right? So cannabis use is legal in many states, recreationally and medically. There's dispensaries popping up everywhere, and there's a ton of misinformation on the internet. So people, it's reasonable that people would try to make sense and educate themselves on whether this legal substance will be helpful to me, especially if I'm experiencing morning sickness or other symptoms related to pregnancy, right? And you might think, or people might think, cannabis is natural, right? This is what I hear in practice. Cannabis use is natural, or cannabis is natural, better than something prescribed by the pharmaceutical company. So I'll take that route. Then you have bud tenders giving out misinformation. There's one study, I think this is this Dixon et al. Study that I have cited at the bottom of this slide. They conducted a study, a mystery caller pretended to be pregnant individuals. They called some dispensaries and said, I'm having morning sickness, do you recommend anything? And the bartenders recommended plenty. So we have to think about What are we going to do? Is this acceptable? Bud tenders giving out information to pregnant individuals, no clinical training. And I'm not saying they shouldn't give out information. I'm saying it should be regulated. If they are, if our states are going to license dispensaries and these bud tenders are going to take, I don't know, whatever short amount of training they take to give out health information, we need to regulate that. We potentially, right? We need to say this is the amount of training you need. It needs to be a standard in order for you to make health recommendations to people regarding cannabis use, or particularly pregnant individuals. It shouldn't just be random. And that's what it is right now. Walk into any dispensary, who knows what you're going to be told? We can regulate this. Why aren't we doing it? That's the global question for us. Now, we can't regulate what people are getting on the internet. That's the Wild West. But we can regulate information that you're getting at dispensaries. And we should. If you're getting information that's contradicting clinical and public health knowledge and recommendations, right? So, actionable step here around misinformation. Why is cannabis use increasing? Potentially due to perceived risk, right? We need more research to examine the causal association between perceived risk and cannabis use. But amongst according to the research we have, this is research from the same study, the National Survey of Drug Use and Health. These are correlations, associations. There has been an increase in reporting no risk associated with regular cannabis use among pregnant people in the US who use cannabis in the past month. This may not be shocking. Point prevalence, sure, 153% increase in reporting no risk. That's a bit surprising. But amongst the population, these are people, pregnant people who are already using cannabis. So there's some face validity there. You're already using cannabis, so of course you may not think it's risky, right? Health education maybe is needed. This is the real shocker. Same study, there has been a 371% increase from 2005 to 2015 of reporting no risk associated with regular cannabis use among pregnant people in the US who did not use cannabis in the past month. Right? What does this mean? Is this a group of people that might go on to use cannabis in later pregnancies? They're at least they're not currently using cannabis, with current cannabis use defined as past month cannabis use. Right? These are all things that we need to think about. Why is there no risk reported? Again, major health organizations report that there's potential risk. We have peer-reviewed research that shows associations that indicate potential risk. But the public, there's a gap between practice, research, and what the public perceives. Whose job is it to close that gap? That's our work. We can't leave it up to the public to figure it out themselves. If we do, we shouldn't have jobs. There should be no public health, right? It is our work, and we're in public health, to ensure the best we can that the public is healthy. But here it is. They see no risk while we report risk. So, cannabis use and mental health. This is a study I published, I believe, last summer. And I see another question. I'll just get through the slides and we'll take some questions at the end. So this study used another nationally representative data set. This is the NESARC, the latest wave of the NESARC. This is the National Epidemiologic Survey on Alcohol and Related Conditions, the NESARC 3. Data were collected from 2012 to 2013. This is a cross-sectional study, and what I did was assess cannabis use and cannabis use disorder and mental health and their relationship amongst pregnant and postpartum women and individuals assigned female at birth. What did we find? It's no new news that when mental health disorders were aggregated to any past year mood disorder, any past year anxiety disorder, any past any lifetime personality disorder, that type of aggregation, that there were significant associations with both cannabis use and cannabis use disorder among pregnant and postpartum individuals. There has been other studies, particularly studies that examine any mood disorder, any anxiety disorder, and mental health amongst this population. But that's as far as the research goes. There's not much representative or large-scale studies that examine personality disorders, lifetime personality disorders, or PTSD and cannabis use disorder amongst this population. The current state of science before this study mainly stopped at mood and anxiety disorders. So the point here is that the top part of this table is consistent with prior research. That's no surprise. There's also no surprise that lifetime personality disorders and PTSD was associated with cannabis use and past year CUD. But what was unique about this study is we were able to disaggregate these mental health disorders and look at specific mental health disorders. So in terms of mood disorder, persistent depressive disorder, major depressive disorder, bipolar disorder, what we find is similar trends, right? So there are positive associations between these mental health disorders and past year cannabis use and CUD amongst pregnant and postpartum individuals. However, for mood disorder, we see that the magnitude of association is stronger between cannabis use disorder and mental health disorders relative to cannabis use, and that bipolar disorder is not associated with CUD, but is associated with cannabis use, right? Similarly, for personality disorders, we were able to disaggregate the personality disorders and study specific personality disorders in relationship to cannabis use and cannabis use disorders amongst pregnant and postpartum individuals. Again, magnitude of association much stronger for past year cannabis use disorder and personality disorder. Same for PTSD. What's unique here is that cannabis use and cannabis use disorder did not share common anxiety disorders, right? There were no common correlates regarding anxiety disorders for cannabis use and CUD, right? When you examine specific anxiety disorders as opposed to aggregate any anxiety disorder, right? So for example, we have social anxiety disorder and panic disorder was associated with past year cannabis use amongst pregnant and postpartum individuals, but not CUD, right? Specific phobia was associated with past year CUD and not past year cannabis use, right? Agoraphobia and generalized anxiety disorder not associated with either. Again, cross-sectional, these are associations. We need longitudinal, well-controlled population-based studies to confirm causality, but we still have to stop and think here, is this an implication for practice? When we're tailoring treatment, we have to think that there are potentially certain mental health disorders that are associated with cannabis use disorder severity. We're increasing in severity from cannabis use to CUD. This is the question we should ask. What mental health disorders are associated with cannabis use? That's early prevention, right? Versus are a potential indicator for early prevention, a potential indicator that can guide early prevention, versus what mental health disorders are associated with more severe cannabis use, particularly CUD. Where and how do they differ in order for me to tailor treatment, in order for me to engage my patients and my clients in early intervention, right? So I talked earlier about walking through the door together. What can we do differently, right? Here's some things that we can begin to do in addition to our work. So implications from this finding, from this study: pregnancy up to 1 year postpartum. I should have said that the participants were up to 1 year postpartum. So this is a critical period where women and people assigned female at birth may be very vulnerable to mental health disorders, cannabis use, and CUD. So now what? What do we do now that we know that, right? We have to think about why. They could be self-medicating mental health symptoms and symptoms related to pregnancy and related to postpartum, right? So what do we do? Even with that information, we have to do something differently. Is it health education? Is it population health campaigns? And this is why we have to do something differently. We live in a social political environment where most states, again, have legalized cannabis for medical or recreational use. And this is not a talk about whether or not cannabis use should be legal or not. It is, and that's fine. But there is not a risk-free drug, right? There are some populations where cannabis use is contraindicated, right? Youth, pregnant individuals, individuals who are postpartum. But medical cannabis use is legal in 38 states and 3 territories in DC. Recreational cannabis use is legal in 24 states, 2 territories in DC. Pregnant individuals, postpartum individuals, are using cannabis for a variety of reasons. We have to understand why. That's certainly the clinical side of it. But the public health, population health, social policy, social justice side of this relates to policy, right? Cannabis use is legal, essentially, in America. The other states, I'm sure, will follow sooner than later, if I had to hypothesize. But cannabis use, substance use in general during pregnancy is not legal. Half of all states have to report prenatal substance use to the authorities, to the Department of Social Services, to the powers that be, right? This includes prenatal cannabis use. 24 states and DC consider prenatal substance use child abuse. 3 states consider it grounds for civil commitment. It is random how practitioners implement these mandatory reporting laws, right? Sometimes they report, sometimes they don't. When we're thinking about racial justice, even when there's no difference in substance use between Black, brown, and white women, Black and brown women are reported more often, right? So we somehow have to check our biases somewhere. But that's the smaller questions. You should be doing that on a daily basis anyway. The bigger question is, why do these laws exist, right? Is it acceptable that we're reporting, if we take the stance that substance use disorder is a disease, prenatal substance use is a health condition? Do we take the stance as the collective public health and medical professionals working in this area, that we're now reporting or continuing to report, because these have been long-standing antiquated policies, continuing to report health conditions? We don't report pregnancy-induced diabetes. We don't report that mom with pregnancy-induced diabetes who had a piece of birthday cake for her birthday or drank that Coca-Cola with dinner, right? We don't report the malnourished mom for not having the right nutrition that's going to impact her fetus, and nor should we. But why are we reporting this? And I'm not talking about a mom who left the baby in the crack house with crack pipe burning next to it. This is not what I'm talking about. Some things have to be reported, but we're reporting health conditions here. and then have the audacity later down the line to say things like, there are so many children in foster care and not enough foster parents. This is because we took them away for no rhyme or reason here. What are we doing about antiquated public health policies that don't promote public health? Besides writing about it or knowing about it or saying, oh yeah, that's sad. 19 states have created or funded drug treatment programs, particularly for prenatal substance use. The question is, I have many questions, but one that stands out should be just the numbers game here. Why are more states focused on reporting or criminalizing prenatal substance use than treating it? The question specifically for us, the collective, is why are we allowing it? Do we really feel disempowered? You know, people say, what can I do? A whole lot. With all of these fancy degrees, we can do a whole lot. Published this paper in Addiction to kind of help us think about it. All right, this is conceptual model. Talk about it more in the paper. Prenatal cannabis use is in the center. This is where we typically are in everyday life. Well, at least from my perspective as a scientist practitioner, prenatal cannabis use occurs. There are poor maternal and child health outcomes that we have to address at the clinic level. And here's the social service level. We're reporting, and clinic level, we have nurses, doctors, social workers, whoever, reporting people for prenatal cannabis and other substance use. We live on this side of the model. This is status quo. And I get it. Having been a practitioner long before I was a scientist, practice is long, hard. And I remember the days of working 12 and 16-hour shifts without a bathroom break, running up and down the ward, feeling like there's no more possibly I can do but keep these patients alive. Like if everyone's alive at the end of the shift, I've accomplished a major goal. What do you mean some more prevention? This is just how it is. The status quo is the enemy of progress, right? We have to figure out how to progress. And this isn't it. Being stuck in this loop is not it. So I want to challenge you, those of us that's working in this field, to not only research and publish about these social determinants of health that are related to cannabis use, but to address them, to reduce them, to somehow reduce the impact of access and availability of cannabis, for example, cannabis use legalization, decreased risk for some, reduce the impact of these social determinants of health on prenatal cannabis use, instead of punishing the pregnant individual for them. Where's the punishment for the system that allows these factors to impact prenatal cannabis use or prenatal substance use in general? Where's the punishment for the system? Who holds the system accountable? If that's not our work, I'm not sure who work it belongs to. It belongs to us. Why am I saying this? Because while we spend our money and our time and our effort in clinical care, which we should, clinical care is needed, right? In reality, when we think about health, things that keep people healthy, thriving, well, clinical care at best accounts for about 20% of that. The rest of the factors are social determinants of health. We cannot bill for social determinants of health. There's no ICD-9 code for it. So maybe this is why we can't address it. We can write about it and publish about it all day, but there's no, I don't want to say there's no progress. There's slow progress to actually doing something because the money is funneled into clinical care, where the impact on health of clinical care is minor compared to that of social determinants of health. We have to demand some things here. We have to change the culture. We have to build the culture of health. I know that Robert Wood Johnson Foundation pushes that. That's where I hear that term often at. build a culture of health. We cannot program or treat, right, with treatment and clinical interventions our way into better health in a sustainable way. We just can't. We have to change the culture. We have to change communities. We have to change the environment. We have to change what's acceptable. We have to change the status quo. If we don't, we accept this. If we don't, we might as well sign the decree that this is what we accept. We accept the current state of affairs as related to the broken systems that impact substance use and recovery, right? I talked about this, fixing the broken system. Population health campaigns like those for prenatal alcohol use would be helpful in terms of other substances. This has been none, fill in the blank. There has been none for prenatal cannabis use, prenatal tobacco use, prenatal opioid use. We can borrow from ideas that seemingly worked and start there. Point of sale regulations. Talked about this some in the earlier slide, right? Training. They're giving out health information anyway. So let's meet the bud tenders where they are. They're already giving out health information. We can lean into it, or we can say, what can we do? Let's borrow from tobacco for 2B, right? I think, was it 2009 or 10? We won 50% of the cigarette labels, we as in public health, 50% of the cigarette packaging, we could put public health messaging on. Are we doing that for cannabis? What's on the cannabis packaging and labeling? Are we just letting that, let's let that go? Can't do anything about that right now. Why are healthcare providers, physicians, nurses, whoever it is that works at the clinic level, face to face with patients, why do they have to decide between patient care and reporting a patient for a health condition like prenatal cannabis use? I wouldn't tell you if I was using drugs. If you were my doctor and I knew you were going to report me, I wouldn't tell you, because I need you to care for me, not criminalize me. Why do we demand? You know how long it takes to go to school? I'm sure you do. You all went to school for a long time, I'm sure. And if you're still in school, you're probably studying for some upcoming test because you're going to be in school for 5 or 6 or 10 more years, school and fellowship. But the powers that be say you have to decide between patient care and patient criminalization when it comes to prenatal cannabis use. You can demand more for your training. This doesn't work. But if you continue to do it, you accept it. Those are just the facts. You accept it. Provider education. Many providers, this according to the research, they have no idea that cannabis use is harmful. And someone put in the chat, like, where's the research on the actual health risk? It's coming. It's coming much slower than practice. They're primarily cross-sectional studies. We need more research. We need more training, right? Time for screening. People are saying, well, it's not as harmful as fill in the blank, crack or opioids. What do you want me to do? I don't have time to screen patients for things, particularly if these things aren't harmful, when I need to work on situations that are actually harmful to my clients. Right? Eliminate these barriers to screening. More stuff that you can do to fix the broken system. Start by repealing some policies that don't make sense, right? Train our scientists and physicians to this, not only to be scientists and physicians, that's what they're looking forward to doing. That's what they signed up to go to school for. But they didn't sign up for this uncomfortable part, to disrupt antiquated systems. That's uncomfortable. Someone's going to experience some negative consequence, either to your practice, to your license, to your reputation. Right. How do you stand? How do you train scientists and physicians to stand in that? Because if you don't stand in that discomfort, to disrupt the system, you accept the status quo. You went to school for half or more than half your life to accept the status quo. Right? Someone has to blaze the trail, and I hope it's you. Right? We need grocery stores, not more stores that sell alcohol, tobacco, or in this case, cannabis. Right? I talked about warning labels and additional research that we need. Right? I called the senator here. I called our senator, our U.S. senator for that matter, in New Jersey. That's Senator Booker. I say call because I intended to call, but there's a web form, right? When I went to the website for the number, there's a web form, right? I simply schedule a meeting with their office to talk about these issues and what we need. They emailed me back in less than 20 minutes because I'm sure I said something in the web form. Here's my contact information at Rutgers or whatever university you were at. That holds weight, right? And I'm sure I said something like Dr. Qiana Brown and something very simple. I would like to talk about prenatal, very simple. Immediately, your credentials hold weight to get you in the door. Doors that wouldn't have been open to you without all your education. So start there. How long did it take me to do this? 5 minutes, maybe 10. Not more than 10, certainly. I like to end with this picture, and I'll take some questions. I see there are questions in the chat, and we can, don't be afraid to dream up the society that you want and then make it happen. I dreamt up Jane's house in honor of my mother. I dreamt up the society that I wanted. And these are physicians. I have to start with the community that I'm in. With Jane's house, I was in Baltimore. I partnered with the Hopkins School of Medicine, and they sent their internal medicine and pediatrics urban health medical residents to train at Jane's house. I wasn't training these people to be physicians. That's what they're in medical school for. That's what they're in residency for. I was training them to be disruptors, right? Disruptors of systems that negatively impact substance use recovery and treatment in women's health. And they were ready to do it. They were outside giving out food, making house calls. And in a community like the one that we served in Baltimore, you see these front stairs here, the front steps in front of a house. Some residents don't have front stairs. So when these physicians had to see a patient inside of a house with no front stairs, and they themselves had to get into the house, they understand social determinants of health a little differently, right? You don't even get to having a transportation barrier if you can't even get out of your house. But they were there doing the work, disrupting the systems. So I'll leave the last few, I'll stop here and take some questions.
I'll just say thank you so much, Dr. Brown. That was a really inspiring, informational presentation. I can tell by some of the comments in the chat that people were really engaged and are coming away with ideas and also questions and want to know what they can do to kind of contribute in this space. One question in the chat is just regarding if you know anything about differences of cannabis use in prenatal populations for rural versus urban. Are there, I don't know if those studies have been done. I think this researcher is just asking that question of what is the landscape out there in that space?
That is a good question. I do not know the answer to that. So hopefully there is some research that is forthcoming or that's already out there that examines urban-rural differences in prenatal cannabis use, because that will be important information to know.
I agree. And it may be, your point there at the end about social determinants of health, that might be the lens or the angle to look at some of that, because those are going to be different and can be different and for rural and urban groups. Exactly. Those of you may see the continuing education screen pop up there. If you want CEUs, please complete that. And if not, you can ignore that. There is another question. It's from a person who's a doula who's trained in holistic, natural, herbal means for mood and health. And their question is, what can we do to focus on reducing risk for women's health? Or do you find education about wellness that can reach the population? Community meetings, group education, neighborhood, school education, boys and girls clubs. And you talk certainly about reaching out to legislative offices. And certainly webinars like this are one avenue for receiving that information. Do you have other thoughts about where folks, so the attendees in this could be a mixture of those who are in academic settings, and they may also be those in community health or private practice types of settings.
Okay. Yes. So I think the first step to educating our clients and our communities, if you will be to listen to them, right? Ask them their perspective. I cannot fill in the gap or come up with any type of treatment or assessment or plan for your need if I don't understand your need, right? So ask pregnant individuals, what are their views on cannabis use? Do they think it's safe? Do they have questions? And then once you meet the community or meet the client where they actually are, you can design an effective educational solution to help that client, be it a individual, be it a clients in a clinical practice, or administrators at a school, right? A lot of people have questions about information, and we can assume what those questions are, right? We have to listen to their need and then address the problem.
Yeah, thank you. And here's a question. It says, viewing with youth court judge and staff, we partner for educational and mental health screening services. Do you have any specific recommendations you'd have for this group of professionals who are interacting with young mothers, parents, and child protection? So those
Sure.
involved with youth court justice systems.
Right. Don't criminalize the evaluation tool, right? So if you're evaluating clients, patients, your client population for mental health and substance use, this information is going to be used in court. The question that stands out to me is why? Why used in court or used in treatment? This can't be a tool. My health screening tool can't be a tool that then that is weaponized, right?
Yeah. It's a great point. It's I don't know if some folks on this webinar are also in Oregon, which is where I am based, and we are sort of both on the forefront and now changing our legislation around criminalization of substance use in public settings. So I'm sure folks on this call have lots of thoughts about that because we sort of in the Portland area took one approach, and the results in part probably because we didn't provide appropriate access to services, um, didn't result in outcomes that were favorable for, well, the literature is a little bit mixed on the individual outcomes, but at the community level, it wasn't beneficial. So
Mm.
um, I know it's the top of the hour, and I also know we didn't get to all of the questions. Uh, so I'm wondering if you are willing for folks to outreach to you individually, and if not, that's also fine. But if you
Yes.
are, what we can also probably do is, for those of you who've asked ask for a specific question or outreach, if it's all right with you, Dr. Brown, we can put that individual in contact with you in the future.
Yes, and I put my email in the chat,
Oh,
in case
great. Okay, thank
anyone
you.
wants
All
it.
right, perfect. And thank you so much, Dr. Brown. It was really, again, you're a very
Thank
inspiring
you.
presenter. I really appreciate your time today. You're bearing with us as we rescheduled you multiple
Um,
times. And thank you to everybody who joined us today for this webinar. We hope you can take some of these nuggets back to the spaces that you're in, whether those are in communities or with families or in your own lives.
Thank you for having
Thank
me.
you.
Thank you, everyone. Bye.
Bye.